HIV and your vision, the complete medical guide you need to know. What if I told you that a routine eye exam could reveal the state of your immune system? And that for people living with HIV, losing your vision isn't just possible, it's preventable if you know what to watch for. Today we're diving deep into the medical science of how HIV affects your eyes, backed by clinical research and expert guidelines. This could save your sight. The HIV-eye connection explained. Let's start with something critical. According to the American Academy of Ophthalmology, between 50 and 75% of people with HIV will develop ocular manifestations at some point during their disease. That's not a small number. We're talking about the majority of patients. But why does HIV target the eyes? To understand this, we need to look at what HIV actually does to your body. Human immunodeficiency virus is a retrovirus that specifically attacks CD4 plus T lymphocytes. These are the commander cells of your adaptive immune system. Published research in the New England Journal of Medicine describes how HIV binds to CD4 receptors on these cells, enters them, and essentially reprograms them into viral factories. Your normal CD4 count should range between 500 and 1,200 cells per microliter of blood, according to the Centers for Disease Control and Prevention. Without antiretroviral treatment, HIV progressively destroys these cells. Clinical staging criteria published by the World Health Organization define AIDS as occurring when your CD4 count drops below 200 cells per microliter, or when certain opportunistic infections appear. Here's where your eyes come into the picture. The eye is what immunologists call an immune-privileged site, but it's not immune-isolated. When your systemic immunity fails, your ocular defenses collapse right along with it. HIV retinopathy, the most common eye problem. The most frequent ocular complication documented in HIV patients is HIV retinopathy, and the statistics are staggering. A landmark study published in Ophthalmology found that 40 to 60% of patients with AIDS affects HIV retinopathy, making it the single most common eye finding in this population. So what exactly is HIV retinopathy? According to research from the Johns Hopkins Wilmer Eye Institute, it's a microangiopathy, meaning the tiny blood vessels in your retina become damaged. The retina, for those who don't know, is the neural tissue lining the back of your eye that converts light into electrical signals your brain can interpret. The hallmark sign is something called cotton wool spots. These aren't actual cotton, they're areas of retinal nerve fiber layer infarction. In simpler terms, small arterioles feeding your retina get blocked, cutting off oxygen to nerve fibers, causing them to swell and appear as fluffy white patches on examination. Studies using fluorescein angiography, a specialized imaging technique, have shown that these cotton wool spots represent focal areas of retinal ischemia. You might also see small dot and blot hemorrhages where capillaries have ruptured. Now, here's the reassuring part. Backed by long-term follow-up studies, HIV retinopathy is typically asymptomatic and causes minimal vision loss. Research published in JAMA Ophthalmology tracked patients over time and found that cotton wool spots spontaneously resolve within 4 to 8 weeks without specific treatment. But, and this is crucial, HIV retinopathy serves as a clinical marker. A study in the British Journal of Ophthalmology demonstrated that the presence of HIV retinopathy correlates with lower CD4 counts and higher viral loads. In other words, it's your body's warning signal that your immune system needs support. The treatment isn't directed at the retinopathy itself. According to guidelines from the International AIDS Society, initiating combination antiretroviral therapy, or CART, is the primary intervention. Multiple clinical trials have shown that effective viral suppression reduces the incidence and progression of HIV retinopathy. Now, we need to talk about cytomegalovirus retinitis, or CMV retinitis, and this is where things get serious. CMV retinitis was once the most common intraocular infection in AIDS patients. Before the era of effective antiretroviral therapy, the Studies of Ocular Complications of AIDS Research Group, a major NIH-funded study, found that 25 to 40% of patients with AIDS affected CMV retinitis. That's nearly 1 in 3 people. The good news is, since the introduction of highly active antiretroviral therapy in the mid-1990s, the incidence has dropped by about 80%, according to data published in Clinical Infectious Diseases. But it hasn't disappeared. It remains a significant threat, particularly in patients with severe immunosuppression. CMV retinitis almost exclusively occurs when CD4 counts fall below 50 cells per microliter. Research from the University of California, San Francisco, published in Retina, identified this as the critical threshold for opportunistic infections. Let me explain the pathophysiology. Cytomegalovirus is a member of the herpes virus family. According to the CDC, 50 to 80% of adults in the United States have been infected with CMV by age 40, but in healthy people, it remains dormant, controlled by T-cell immunity. When HIV decimates your CD4 cells, CMV reactivates. The virus has a particular affinity for retinal cells. It causes full-thickness retinal necrosis, meaning it literally destroys all layers of your retina. On fundoscopic examination, you see characteristic findings: fluffy white areas of retinal opacity with associated hemorrhages following the distribution of retinal blood vessels. This creates what clinicians describe as a pizza pie or cottage cheese and ketchup appearance. Graphic, but medically accurate. A study in Archives of Ophthalmology followed untreated CMV retinitis patients and found a devastating progression rate. The infection advanced at approximately 24 micrometers per day. Left untreated, it leads to retinal detachment and irreversible blindness, typically within 4 to 6 months. But here's where modern medicine shines. Treatment options have evolved significantly. According to the American Academy of Ophthalmology's preferred practice patterns, management includes systemic antiviral therapy, medications like valganciclovir, ganciclovir, foscarnet, or cidofovir. A randomized controlled trial published in The Lancet showed that oral valganciclovir was as effective as intravenous ganciclovir for induction therapy. Intravitreal injections, direct injection of antiviral medication into the eye. Research from the Journal of Acquired Immune Deficiency Syndromes demonstrated that intravitreal ganciclovir, or foscarnet, provides high local drug concentrations with fewer systemic side effects. Sustained-release implants, the ganciclovir intravitreal implant, studied extensively in clinical trials, releases medication over 6 to 8 months and has shown superior efficacy in controlling retinitis compared to systemic therapy alone. But the absolute game-changer is this. Multiple studies, including the landmark research published in AIDS, have proven that immune recovery through antiretroviral therapy is the most effective long-term strategy. When patients achieve sustained CD4 counts above 100 cells per microliter for 3 to 6 months, they can often discontinue maintenance therapy. This is called immune recovery uveitis. Other ocular complications you should know about. CMV and HIV retinopathy aren't the only threats to vision. Let me walk you through other conditions documented in medical literature. Herpes zoster ophthalmicus. This is shingles affecting the eye. According to research in ophthalmology, HIV-positive patients have a 15 times higher risk of developing herpes zoster compared to HIV-negative individuals. It causes severe pain, rash around the eye, and can lead to corneal scarring and vision loss as the varicella zoster virus reactivates when immunity drops, and studies show that antiviral therapy with acyclovir or valacyclovir is essential to prevent complications. Toxoplasma retinochoroiditis, caused by the parasite Toxoplasma gondii, creates focal necrotizing retinitis. A study in Clinical Infectious Diseases found it occurs in 1 to 3% of AIDS patients. Unlike in immunocompetent patients, where it's usually a reactivation of congenital infection, in AIDS patients it's often newly acquired and more aggressive. Kaposi's sarcoma. This is a tumor caused by human herpes virus 8. Research published in Survey of Ophthalmology documents that ocular Kaposi's sarcoma appears as reddish-purple lesions on the eyelid or conjunctiva in about 20% of patients with systemic Kaposi's. It's more common in men who have sex with men and typically appears when CD4 counts are below 200. Microvasculopathy. Beyond cotton wool spots, HIV can cause chronic microvascular changes. Studies using optical coherence tomography, cutting-edge retinal imaging, published in Investigative Ophthalmology and Visual Science, have revealed reduced retinal capillary density even in asymptomatic HIV patients on suppressive therapy. Dry eye disease. Research from the Ocular Surface Journal found that HIV-positive patients have significantly reduced tear production and increased ocular surface inflammation. The virus can directly infect lacrimal gland tissue, and medications like antiretrovirals can exacerbate dryness. Uveitis. Inflammation of the uveal tract can be infectious or non-infectious. A particularly important entity is immune recovery uveitis, which paradoxically occurs when patients start ART and their immune system wakes up. Published case series in American Journal of Ophthalmology describe how recovering immunity can trigger inflammation against residual CMV antigens or other pathogens. Neuro-ophthalmological complications. HIV can directly affect the visual pathways. Cryptococcal meningitis, for instance, can cause papilledema and vision loss through elevated intracranial pressure. Primary CNS lymphoma can compress the optic nerve. Studies in Journal of Neuro-Ophthalmology documented about 10% of HIV patients experience some form of neuro-ophthalmological manifestation. The prevention and management revolution. Here's the most important message, supported by decades of clinical research. Antiretroviral therapy has fundamentally changed the landscape of HIV-related eye disease. The data is overwhelming. A meta-analysis published in The Lancet HIV reviewed 25 years of studies and found that patients on effective ART with undetectable viral loads have an 80 to 90% risk of developing opportunistic infections, including ocular complications. What does effective ART mean? According to the Department of Health and Human Services HIV treatment guidelines, it's a combination of at least 3 antiretroviral medications from 2 different drug classes that suppress HIV RNA to undetectable levels, typically below 50 copies per milliliter. The Multicenter AIDS Cohort Study, one of the longest-running observational studies, published findings in JAMA showing that patients who maintain CD4 counts above 500 have near normal life expectancy and minimal risk of opportunistic infections. But medication alone isn't enough. The American Academy of Ophthalmology recommends specific screening protocols. CD4 count 50 to 100, dilated fundus examination every 3 months. CD4 count below 50, dilated examination every 1 to 2 months. Any new visual symptoms, immediate ophthalmological evaluation. Research from ophthalmology demonstrated that systematic screening detects CMV retinitis before patients develop symptoms, allowing earlier intervention and better visual outcomes. The HIV Medicine Association of the Infectious Diseases Society of America also emphasizes that patients should be educated about warning signs, floaters, flashing lights, visual field defects, or progressive blurring. These require urgent, meaning same-day or next-day, ophthalmological assessment. The future of HIV eye care. Before we wrap up, let me share something hopeful. The future is bright. Researchers are developing long-acting injectable antiretrovirals that require dosing only once every month or 2. Studies published in the New England Journal of Medicine show these achieve viral suppression rates comparable to daily oral therapy, potentially improving adherence. Advanced imaging techniques like OCT angiography are allowing earlier detection of microvascular changes before they cause symptoms. Gene therapy approaches for retinal repair are in development. And perhaps most importantly, with effective treatment, HIV is now considered a chronic, manageable condition rather than a death sentence. The message from the Joint United Nations Program on HIV/AIDS is clear. People living with HIV who achieve viral suppression can expect normal lifespans and excellent quality of life, including preserved vision. Conclusion. Let me bring this all together. Your eyes are not separate from your immune system. They're a window into it. HIV can threaten your vision through multiple mechanisms, from microangiopathy to devastating infections. But the medical evidence is crystal clear. Early diagnosis, consistent antiretroviral therapy, and regular ophthalmological monitoring can preserve sight in the vast majority of patients. If you're living with HIV, your action steps are straightforward. Take your medications as prescribed, keep your appointments, and never ignore visual symptoms. If you're a healthcare provider, remember that eye exams aren't optional, they're essential preventive care. Knowledge backed by science is power.
If you found this evidence-based breakdown valuable, subscribe for more in-depth medical content. Drop a comment with questions. I read them all. Thank you for watching, and remember, protecting your vision starts with understanding the science behind it.